time has come to shift and now embrace the new social insurance funding. And of course, with all this, are we really prepared for this new, funding? And how should we navigate through this? And of course, to help me unpack this discussion is my guest, Wanja Maina. She is a passionate feminist and Pan-Africanist, dedicated to advocating for the rights of African women and young women with disability. And of course, another my guest is Brian Malika, founder of 1 More Percent. Lady, and of course, gentlemen, asante sana for making time. So right away, it's just a matter of days before we now shift to this new social insurance fund shift from the current one, NHIF. And of course, there has been some concerns in regard to this, funding. Some call it as a game changer as far as, healthcare and of course, health insurance is concerned. But given the reservations from even the stakeholders themselves, and now the concerns that have been raised by Kenyans. So, first of all, and I'll begin with you, Wanja, do you think we are ready for this new funding from the new social insurance fund?
Thank you very much, and greetings to all viewers of KUTV for this opportunity. As you rightly put, July 1st is when we are supposed to shift to the new healthcare model. And even before we get to July 1st, which is in less than 3 days to come, the committee that is in charge has already cited issues to do with ICT challenges, especially when it comes to registration of this SHIF or SHIF. And this is particularly of great interest because in the past we had an HIF and then we had that plastic card. Now we've been told that with SHIF, all one will need is a SHIF number. Another thing that I foresee as a challenge really is just our ability as Kenyans to enroll and take health insurance seriously. Some Kenyans do not go to the hospital because they cannot afford. Others do not see insurance really, and it's even part of our culture. In other cultures, people write their wills, they talk about what will happen in their demise. But in our African setup, really, no one really plans for disease. God will help us. Why are you thinking about paying all that money for health insurance? And that is actually reflected in the statistics. I read that less than 25% of Kenyans, as it were, have a form of health insurance. So it's like we leave things to fate. Health really, why are you planning to get sick? When you see an African writing a will and talking about what will happen after their demise, they'll be asked, you're talking about death. So we are people whose culture does not really think a lot about bad things that would befall you, like illness. As women, we are also quite struggling with the fact that Linda Mama in this SHIF is scrapped. In fact, I was reading some data that with this SHIF, to give birth will be 11,200 for a normal delivery and that 2,600 for a CS. Right. But for women who give birth, they'll tell you that when you have a child in your stomach, you don't know if it will be a CS or it will be a normal delivery. Right. We know that giving birth in Kenya is a matter of life and death, especially for women from underserved communities. I'm imagining people who cannot afford now generally avoiding to go to the hospital because they can't afford. I'm seeing quack midwives having a very good time. I'm also seeing that could affect the health of the children. So those are some of the concerns that we have. But generally, there is no clarity of this SHIF. I feel like there could have been more awareness raising. Where is this model coming from? What are the benchmarks? What are the best practices? How did they arrive at it? Okay. We have always talked about issues of public awareness and public participation.
Okay. Brian will talk about now, where and of course how we can even move forward. But when you look at the consideration and some of the concerns that the stakeholders, the health stakeholders committee that had been given the mantle to actually assess the situation and come with a report to lay bare and set the framework for this shift to actually kickstart, they came with some reservations, and they thought that maybe the 1st of July is not the right time to begin this particular process. But nonetheless, Health CS Susan Ahumicha has already announced that beginning of 1st July, that is when Kenyans will begin to register for this new social insurance fund. And of course, notwithstanding some of the concerns, do you think probably maybe we rushed on this one?
When you say, okay, hi viewers, thank you for having me in studio tonight. Okay, when you use the term reservations, the elephant in the discussion or in the room was that there has not been enough public participation among members of the community, talking about like the civil society, like direct beneficiaries, direct internet beneficiaries, and just that discussion or that dialogue across the country hasn't been facilitated well. So the dialogue about migrating from NHIF to SHIF has been in closed spaces where ordinary people couldn't reach. And that is why members of the civil society particular, and even the media people, and Kenyans of goodwill are saying that it's being rushed. Yeah. So that is why there's that concern. Yeah. But when you look at moving from, we first had NHIF in 1966. So it's a program that has been running for 57 to 56 years. And when the analysis why there was an intention to migrate from NHIF to SHIF was that the NHIF was putting everyone in the same box, like equality, like treating all Kenyans the same to access healthcare. But across these 56 or 57 years, we've been able to find out that all Kenyans are not the same. Kenyans are not the same in the amount of money they earn, in the amount of the diseases and sicknesses they have, in the social and social challenges like environmental. And that is why the discussion for having SHIF began. So it's a discussion that is geared towards, it's actually a discussion that started in 2013. Like after 3 years we had the new constitution. The new constitution says that all Kenyans have a right to healthcare. So that discussion started in 2013. We said we need to have the Universal Healthcare Act. That is why the SHIF, the Social Health Insurance Fund, the discussion started. So we're moving from equality to equity. So equality, NHI was about equality, whereby everyone is treated the same. But now equity, now everyone is treated based on their own needs. However, as you had stated, this discussion has not penetrated in villages, in interior parts of the country. It's a discussion that has been taking place in elite spaces. That is why people are not ready. Yeah.
All right. And when you talk about now, lack of proper public participation, because a process like this need proper participation, civic education, and of course rigorous engagement from the members of public so that they can set up this mechanism and even lay bare some of the recommendations and their plan going in future. Do you think probably this disconnect between probably the education that members of public actually need versus now, what actually the intended purpose of the government? Do you think probably this is why majority of Kenyans feel like this discussion it hasn't captured all the aspects incorporated as far as this new social insurance fund is concerned, the new model?
Thanks so much. A rose is still a rose, even by any other name. If you call it SHIF, if you call it NHIF, if you call it Kenya Care, or is it Obama Care, like in the case of America, if you call it Health for All Care, a name is just a name. I think for me, this, what is it called? How will it be called? from whom it will be named after, for me, I'm looking at, so what does it mean for me to be on the SHIF or the new healthcare program? You know, one of the things about health in Kenya is that health is a devolved function.
All right.
But also at the same time, even though health is a devolved function, we have seen cases where, and when I say health is a devolved function, Article 43 of the Constitution says that every Kenyan has the right to the highest attainable standards of health. Ideally, what that should mean is that if I faint here, I believe in rural constituency, I should be able to receive the highest attainable standards of health as I should be able to receive in Wanja, for example, or if I faint in Dadaab or Fafe or Gatundu.
Okay.
But then again, we have seen over and over again that not all health is not really the same. Let me give you an example of a hospital called Kiambu District Hospital. The county government of Kiambu was saying that around 40% of the patients who come to our hospital are from Nairobi County.
Okay.
So they were raising debates around, is there a way that a county that in Nairobi can help us to cater for our health budget because 40% of the patients are coming from Nairobi? Then the question emerges, why is it that if I'm sick in Mathare or in Isli, I choose to go all the way to Kiambu District Hospital? Then it tells you that the services provided in government hospitals are not all the same.
All right.
We have seen cases, for example, and how I came to arrive at this conclusion was when we had doing the piloting for universal health care. I believe the counties that were chosen were Nyeri, Machakos, Isiolo, and Kisumu. Those were because these issues are interconnected. So why did they choose Nyeri? Because Nyeri has the high, in Kenya, most people with non-communicable diseases are in Nyeri, the diabetes of this world and other diseases. We are talking about Isiolo, whereby there is high cases of maternal mortality.
Okay.
Then if you are talking about equity, the fact that even under NHIF, women are dying more when they are giving birth tells you that if you introduce something like 11,000, you are actually punishing people who are already suffering. So what am I saying? The fact that health is a devolved function tells you that if SHIF, and when you mention the CS of health, tells you that these are sort of a national government-led initiative, assuming it is, then the question is, how will this SHIF information and public participation information now revolve to the counties? Because in the ideal version, I should not have to travel from Nairobi to go to Kiambu District Hospital. Right. And that is where now issues of awareness, issues of the quality of healthcare, issues of investment in health in county hospitals, and also, you know, these issues of health is that counties are already having competing priorities. Remember, counties themselves rely on national government to give them money.
Okay.
Now that explains why we have had issues of the strike of doctors, the strike of clinical officers. So whether I'm in the SHIF or in the NHIF, the fact that clinical officers just stopped their strike like 2 weeks ago, it means that regardless of which program I was in, if I went to a health dispensary, I wouldn't get the health. You know, you remember the doctors' strike that the doctors were dancing like a month ago. So for me, I'm seeing a situation where we have to really treat not the symptom, but the root cause of this disease.
Right.
What is happening with our healthcare? How come we are hearing funny stories of women giving birth at home or having to travel for so far to access health? I think those are, for me, are the real issues, other than just focusing on what is the new name. So what does it mean for a person who is unwell now and they're struggling on whether to take their child to the hospital now? I think for me, those are the real issues.
Okay. And talking about issues, there is another concern, and this is the 2.75%. And now, under this model, of course, we have now the contribution in terms of the deduction. It's like the more you earn, the more you pay. Unlike the previous one, where the maximum was 1,700 shillings, that is 1,700 shillings. So in terms of equity, do you think there is equality in this? because these are some of the concerns that have been raised with Kenyans. And another very critical area that we'll touch on this very important aspect is now, how do you identify the vulnerable household? That is another very critical question. So first of all, to you, Brian, do you think there is, equality in all this?
I think, first of all, people who are working, especially civil servants, and even people in the corporate world, just people who are working, 2.75% of their income will be accredited to SHIF. And then people who are working self-employed or in informal sector, they will have to give 300 shillings at per everyone. And then people who are not employed and for some reason they don't have money, they will be enrolled into the program free of charge. So that is why it is now a social health, like it's more of a social health coverage. And when you compare it to NHIF, everyone was supposed to pay 500 shillings if you're not a civil servant or if you're not employed. So whether you have money or you don't have money, you're supposed to pay 500 shillings. And then people who are employed, there's a package you're supposed to pay. So I feel that this model is taking resources from people who have a lot, and then people who have few or little, and then people who have nothing, and then stabilizing it so that everyone can access healthcare. Yeah, and that is in realization that we have people especially people who are working and people who in community who are well off, who have benefited from the society. It's a form of giving back. So NHIF was a pooling model, was an insurance model where you pool funds. Like if you go to any other insurance company, you pool funds together and then you minimize the risk. But this one is putting everyone on board, or putting everyone under the umbrella. So that is the difference. And whether it is right or wrong, I cannot say that, I cannot judge. But what I can say is that the discussion has to be taken to the people, so that people understand it, people talk about it, and then we know the merits and the demerits. But from my experience, this is a model that works very well in Scandinavian countries, like in Denmark, in Sweden, in Norway. This is the model that works there. Where in Norway, if you don't have money, you can be treated. Okay, but NHIF is a model like works in the States. If you don't have money in the United States, in the UK, you will not be treated. So those are two models.
Okay.
Yeah. So we are moving from equality to equity, and whether it works or not, I cannot tell.
You cannot tell. Yeah. Fair enough. And when you look at now, another very area of concern is the aspect of how do you know that this family is vulnerable, the criteria to use during this election, so that for those who can't afford, the government can provide for them, even the county government, the way it is stipulated in this particular, SHIF Act. So how do you know that there's a very vulnerable, family or household, and they deserve to be catered for? Because that is another critical question.
Thanks so much for that question. And so if you allow me, before even I go back to before I answer your question, there's something you mentioned about the 2.5%. Now remember, before we have come to this shift that is going to start in July 1st, there has been a number of litigation. In fact, the matter was subjected to a 3-judge bench where we had some of the unionists arguing. In fact, I remember one whose name I forget, describing shift as outright exploitation of workers, because of the view that 2.5% is quite a lot. Whenever people say that the people who are working, they have money, therefore they should contribute to the pool, you are forgetting that we are Africans. The people who work in Nairobi and they have government jobs, you're forgetting that they have a lot of dependents in the villages. The child of the uncle of the grandmother, help here and there. So already the people who are working have a lot of family obligations and the black tax. So overburdening them with taxing for them more is not necessarily a good thing, because they're already having obligations. But to answer, you have asked a good question around how do you identify the vulnerable people. Well, and I would say even vulnerability is subjective and debatable, because when you say I'm vulnerable, relative to what? It's like saying you are short. So you are short relative to what? I mean, if you stand before a basketballer who is 6'5", you are short. But if you stand before a short stature person who is 3'1", you are tall. So this issue of saying these are the vulnerable people in the society is relative. Subject to what? You know, when they say that the vulnerable people, like the people with disabilities, and the old and the orphans and the vulnerable will be identified, then we can look at so far what they have done. Say the issue of social protection in Kenya for the vulnerable. On paper, these people who are poor and vulnerable, they should be given 2,000 shillings according to what is said. However, when you go to the ground and you meet the old people, they usually say first, receiving the 2,000 shillings is not predictable, nor is it regular. Therefore, you'll find like, kama wangefaa kupewa pesa January, inakaa maybe mpaka June, and then they are given like half of it. Therefore, it tells you that so far, the government is not keeping their word in regards to helping the vulnerable people. We have seen pensioners crying. So the question is, if they are predicting that they'll be able to help the vulnerable and the disabled by having a model where they'll be able to be treated for free, how sure are you that it will be predictable and regular? Because when you're looking at, for example, a disabled person, accessing healthcare is a matter of life and death. We have children with severe problems that require a lot of medication regularly. We have children who, I don't know what's called, fainting or conversing, or I don't know what's called. So what am I saying? So far, they are not necessarily good at keeping their word for the vulnerable, and therefore the question would be, how sure are we that these monies will be regular? Okay. So those are the issues that are coming to mind, and also really just reaching. You know, sometimes when we are in Nairobi, we are quite privileged. Whenever I walk near my neighborhood, I can see a lot of community hospitals and a lot of clinics and pharmacies. But Kenya is really big. When you travel, really, that's when you see many things. There are some far-flung areas where you have one clinic with just one nurse. The nurse is the cleaner, the doctor, the nutritionist, and what have you. So it also begs the question on a lot of employment of healthcare providers. There are a lot of unemployed doctors, clinicians, those people in that field of healthcare. Okay. That way, then it will go hand in hand in ensuring that the shift is working.
All right. So apparently, I'm being informed we are really running out of time. I'd like to take this moment to thank you all for making time. Wanja Maina is a passionate feminist and Pan-Africanist dedicated to advocating for the rights of African women and young women with disability. Asante sana for making time.
Thank you.
And Brian Malika, founder of 1 More %. Asante sana, Brian, for making time.
Thank you.